Part 2. So what we've done is put together for you a case study that is very real to us as a team. It was someone that we've been involved with just a couple of months ago. And what we're hoping to do is all the previous things we were talking about, and probably things that you've learnt today and you've heard today, is we're just going to give you a real, nuts and bolts case. This is a real person and what happened. So we're trying to reflect that the patient and the family were central, okay, in terms of our practice. Just to bear in mind that there's theoretical things, like Clara was saying, in theory things are great, what we should do, how we should deliver care, but the reality can be very different, okay? And there's always conflict, and there's always conflict for us between the needs of the patient versus the needs of the organisation, okay? And you'll see this more and more and more when you're out there working in hospital environments or whichever environment you're working in. There's always going to be a pressure from someone else. And it's always about quality of life versus quality of care versus expectations. And the expectations are just the patient's expectations, the family's expectations, and our expectations as health professionals. So this is what we're dealing with. So we've called in Peter. So Peter, 36-year-old Aboriginal gentleman. He presented to Broome Hospital, emergency department, with severe right pleuritic pain on the 12th of December last year. All of the symptoms at that time, overall, in terms of looking at him, he was well. He was well. He'd had intermittent pain for 3 weeks, a bit of back pain, a bit of flank pain. It was all a bit vague what the problems were. Further on, he'd had a painful spine, sternum, ribs, and on palpitation. So that was just on the actual physical assessment. He'd complained of feeling tired, a bit lethargic, didn't have the same energy levels. He'd lost heaps of weight, and they were his words that he'd lost heaps of weight. He'd lost about 5 kilos. In Broome, he had a chest X-ray. He was found to have a pleural effusion and some lower lobe collapse. And then he had a CT of his chest in Broome and was found to have some mediastinal nodes and some pleural fluid. The decision was to fly him down to Charlie's. So on here, it's not easy to see. This is tumour, and this is tumour here, okay, on that one. We'll come back to them.
Do you want that one?
I'll just have a little look at this just so you can see. This is a PET scan. Okay, I don't have anything fancy to show you, but a PET scan lights up, okay, in certain spots. So we've got problems with adrenal mets, and we've got quite a lot of light showing up in his ribs and in his spine and sternum. So he was flown down with our FDS from Broome. He arrived at Charlie's on the 14th of December. He'd had the PET scan, which was the one I just showed you, which was suggestive of metastatic malignancy. So when he actually arrived, they were actually querying whether he'd got TB. That was the actual original sort of temporary diagnosis. So he had an absolute plethora of tests and investigations. He had a pleural biopsy, and that was the thing that definitively showed that he'd got this very rare differentiated hepatoid malignancy. You can Google that, you can learn about hepatoids, you rarely see them. They're a very rare type of lung cancer. Prior to this, there'd been a whole host of other investigations. On admission that particular time, his pain had settled well with a bit of paracetamol, some non-steroidals, and he'd had a small dose of slow-release oxycodone commenced, and he was discharged from Charlie's initially. So a week or so, just under a week later, he was readmitted with further chest pain, epigastric pain, pleuritic chest pain, and now he'd got some dyspnea, some significant shortness of breath. And on the 29th of December, this gentleman was referred to our team, okay? So we got to meet him on the 29th. So that was a referral for pain management, okay? So that was one of the things. It's one of the main things that we do at Charlie's as a palliative care service. We're classed as one of the pain teams. So we got involved. You can see that very quickly he'd gone from having a small dose of oxycodone of 5 milligrams twice a day to 40 milligrams over the next 4 days. So this gentleman was really getting into problems very, very quickly with his pain. When we met him, he was drowsy. He was unable to give us a good history. His family, all his brothers, he had a whole host of brothers with him. The most beautiful men you'd ever wish to meet. They were just so caring, so supportive, and were a great source of help to us in terms of, getting all the information. He was intermittently jumping in bed with apparent spasms. He basically got some myoclonus. So he was having some really quite toxic side effects from the medication at this point, and he was distressed. He was visibly distressed. So what do? We look in, we come in, we see all these problems, and we've got to try and get this gentleman's pain under control and reduce the toxic side effects, okay? We don't want him to be drowsy, we don't want him to be jumping, we want him to be being quite comfortable, being able to communicate with his family. So sedation, causes of sedation in this setting: sepsis, the analgesics, possibly, hypocalcemia. Hypocalcemia is very, very common in advanced malignancies, particularly in people with lung, breast and prostate cancer. Put cannabis up there because our lovely friend liked a few cookies now and again, and he was still having them intermittently when he was outside the hospital, and he was exhausted. This poor guy was absolutely exhausted. He'd not slept for days and days and days because of the pain. So what are the causes of the pain? So this is us. We're in there now trying to problem solve as a team. So we knew he'd got pleuritic pain arising from the fluid, and he'd got infiltration into his pleura. He'd got bone pain arising from the sternum and the ribs and his spine. He'd got neuropathic pain, possibly, okay, arising from the spinal disease, compressing on his spinal nerves. And then, of course, there's the emotional side of this and the social connections. He's away from home. He's away from loved ones. Even though he's got some loved ones there, he's away from Broome. How scary would this be? He's 36 years old and his things are just falling apart fairly rapidly. And so our conclusion was he's got what we call a mixed syndrome, pain syndrome, of both nociceptive, neuropathic pain arising from all of those things. So he's got multiple reasons to have pain. So when we're assessing pain, we need to identify the cause. We need to consider different types of syndromes. Neuropathic pain, which is nerve pain, okay? Specifically nerve pain, when it presents, is very easily identifiable. People get pins and needles. They talk about stabbing pain, burning, okay? Those kind of symptoms. And then the other thing that's always in the forefront of my mind when I meet a patient is about anxiety and fear, okay? Because guess what? It increases pain. Hypocalcemia also increases pain. So if a patient comes in with hypocalcemia and pain, there's a high chance that their pain would have escalated due to the hypocalcemia. So what do? We've got to do what we call an opioid rotation. So all that means is we're going to take this guy off all his current analgesics and put him onto something completely new. Okay. Now you can imagine when we're doing that, it's a pretty critical time because, he's got used to these particular medications, but we know they're not working. We can see they're not working. He's got pain and he's got side effects. So we have to rotate to something new. In this instance, he was changed from oxycodone to a drug called hydromorphone. Like today, we're not here to do all about the analgesics, but, you can look these things up. You'll come across them in your practice. And then the other thing that we always consider in palliative care is what non-pharmacological things can we do for this guy? So in palliative care, it isn't always about withdrawing treatments, which is often a misconception. We often will initiate or advise treatments for patients. And in this case, it may have been radiotherapy. So radiotherapy is a really good treatment for pain and managing pain, particularly with people with bone metastases. So he had an initial improvement when we met him. For a couple of days, he was really good. And in terms of who was visiting him, what was happening on a day-by-day basis, he was actually under the care of the respiratory team. He wasn't under oncology at this point. He was being seen by respiratory. He was being visited by medical oncology, trying to work out a plan. But we were the people that were in there every day looking at his symptoms, okay, trying to manage his symptoms and trying to support him and his family. He had a very, very difficult couple of days and his pain dramatically escalated very suddenly. So with this, he wasn't getting a great deal of relief. He was getting more symptoms again, more intermittent jerking and more problems. So we thought there was something more going on, and we had to investigate further whether there was some compression in his spine or whether he was having some complications in his abdomen. Okay, why have we got a slide of Point Walter in the middle of this? You're probably all wondering. So what happened is, within this time frame, you know, it's a couple of days, it's just around Christmas time, it was his birthday. And we'd had a couple more days working with him. We'd got his pain back under control. And how we'd done that is we'd actually got this gentleman on a syringe driver now. We'd got him on a continuous infusion of pain relief, okay? So he wasn't taking any analgesia orally anymore. It was just via the syringe and the infusion over 24 hours. He was feeling fantastic, okay? And it was his birthday and he wanted to go and celebrate. So he did, and we supported him. So he trotted off to Point Walter, had a barbecue. And the next day when I came into work, we'd heard from the ward that he'd gone AWOL that night, or for a period of time he'd gone AWOL. And they'd phoned the police at 1 a.m. Because he hadn't come back to the hospital. The ward were fantastic. That's okay, he'll come back. And he did, and he'd had a great time. He was just having fun. So being flexible. If you've got an advanced malignancy, you're going to die potentially from this. Flexibility is the key. So he's back in hospital, and we're still working. We're still trying to get things under control. We've got a cocktail of drugs that are going on. There's lots of discussions now. We're starting to talk about whether he wants to go back to Broome while he's waiting for a chemotherapy plan, or whether he's to stay in Perth. His decision and the family's decision was he wanted to be near the medical expertise. He felt safe at Charlie's, and he was starting to build some lovely rapport with both the nurses on the ward and with our team. Chemotherapy was about to start, okay? So because he had a rare tumour, it took quite a while to get the histology, and there was a delay. That's why there was these delays in treatment starting. So he started his treatment. He had increasing anxiety, though. The longer he was with us, the more anxious he was getting. We did improve the pain. He had some radiotherapy, he'd started chemotherapy, and we started to decrease his opioids. So, you know, we were having some wins with him. And then he was discharged again on the 29th of January. And this is where I'm going to flick to Clara, okay, to just tell a bit more of the story.
Right. I'm just going back to this slide, really because this is a piece of work done by Jane Johnson, and it's in one of the guidelines of working with Aboriginal people in palliative care. And it's a beautiful depiction of the web of care, which really reflects teamwork as well. Social work and palliative care want to know not just about the patient, but about their family system. And what this depicts, this black represents the physical body, and the white represents spirituality. This represents the immediate family, and the little dots inside of the extended family. This thick line represents the connection to land, and these lines represent like the palliative care in the hospital team, and then these are the community workers. So I guess from a social work paradigm, that's what I want to know. I don't want to just be in that traditional medical model just looking at this. And often in hospitals, that's what we're looking at. But this actually gives us the paradigm of how we needed to be understanding who this person, Peter, was. So really where I came into it, I wasn't involved in that very first admission, but I met Peter on the 7th of January, and I'd been told about this most gorgeous, beautiful person. So I was really excited to meet Peter. But when I went in, he was sitting there downcast, really miserable, probably in quite a lot of pain on that day. And he had a cousin and a brother with him. But rapport building was really hard on that day because it was bad timing when I went in there, and I was asked to go in to find out all these questions. Who's in the family? Does he want to be in Perth? Does he want to be in Broome? The doctors were all relying on this information. But again, it wasn't about, you know, my goals. I wanted to get this information. This wasn't great space for him, and it was very hard to get clear information. Usually I like to meet people, build that rapport, and use that assessment starts to unfold. So that's kind of where it started. But it really changed from there because over time, you know, I had lots of opportunity to meet with Peter, but often it wasn't in his room. And it was often with a family meeting in the corridor, outside, and slowly I got to know who this person was and the family structure. So Peter had a partner in Broome. He had an 8-year-old son. There were, I think, 10 siblings. He was very, very close to his mother, and his mother was down in Perth, and there was a number of relatives that were staying in Perth. And they were just with him, and they weren't budging until there were further plans, and his mother was quite unwell. Peter, from very early on, any questions that I asked of him, he was deferring the decisions to his family, to his mother. I'd need to speak to my mum. So again, that Western thought of speaking to the patient and getting it from the patient, in this case, it wasn't really relevant. The family's input was really important. So again, my focus was being asked to do the discharge planning. So we'll get his symptoms settled. Where can he go so that he can have his chemotherapy treatment where he doesn't need to be an inpatient? So I'd organised for him to go to Crawford Lodge, which was next to the hospital, and that was, I think the 20th of Jan, and we'd booked for the 9th of February. So you've got a little wait, but this patient was still really sick, and I thought that was reasonable. He was happy to stay in hospital. Family were happy for him to be there. But then what happens, the hospital's saying, no, you can't keep him in a bed until the 9th of, I think we've missed February. One here, 9th of Feb. So what happened was really we needed to explore what were the other opportunities for this patient. Now, he would have been quite happy probably just to stay there, and the family were happy, but we went through the motions, and there was a lot of coordination involved with OTs, with Silver Chain Hospice, getting oxygen. We needed to train that family to support him whilst he left hospital. Still quite an unwell man. His pain was better controlled. There was a lot of work, and there were missed appointments because times were set up for oxygen to be delivered, and the family weren't there at the time. So then the ward staff are getting upset because there was another delay. So this is the kind of pressured environment you're working in. So then he did agree to go. He said, look, I'm not happy about it, but I'd like to be out of the hospital and we'll give it a try. So he went out on the 29th. You can go to the next slide, Karen. So on the 29th, he was discharged from hospital and he was readmitted the day after. And at that point, he was really quite unwell. He had been brought in, suggested by Silver Chain Hospice to come in. He'd had a temperature. He was physically unwell but incredibly anxious, and the family were really anxious and upset. I saw him, there was a weekend, and I caught up with him on the 2nd of Feb. And by that time, he'd really calmed down, being back in the hospital environment. And the family said, we need him to be in hospital. He's very unwell. His mum had said the best care for him is in the hospital. So we had this elderly lady trying to help her son in an apartment in the city for him to get into the toilet, and the way she moved the wheelchair, they crashed into the wall. It was all a big disaster, and they all got worked up. Then he was sick as well. But, this was the kind of stress that we were putting on this family, where they were actually quite happy for him to just be in hospital. So at that time, we thought we really need to address this anxiety. So we referred to the clinical psychologist at that point. And Peter was very happy. He was drawing a lot. He had a real connection to the ocean coming from Broome. Water meant a lot to him. So he was really missing home. But he wanted to be in a safe place and he wanted treatment, so he's happy to stay in Perth. So at that point, we really clearly said he is not leaving until he can go to the other accommodation where there's a bit more support. His partner came from Broome, and she brought in a whole nother story. So that assessment of that family expanded and changed, and I won't get into the details. But slowly, you're getting to know who these people are. Generally, I would be doing that estate planning that I was talking about wills, what's happening with your son, all of that. That was a little bit chaotic because there was so much toing and froing as to where he was going to be. So then my consultant said to me, David Dunwoody said, do you know what, are we doing the right thing, keeping him in Perth? Shouldn't we think about getting him back to Broome? What if he never gets back to Broome? So at that point, it was like, oh God, this is going to be stressful, because then I had to talk to everyone again, the oncologist, the discharge coordinators, to see if that's possible. He would have needed a nurse escort. He would have needed I don't know if it would be RFDS. So there was cost involved. So it's like the needs of the patient, but you're thinking about the economic cost as well. There was a lot of discussions, and in the end, we felt that because Peter really wanted to have treatment, and he felt safe near the hospital, and there was a risk that if he went to Broome, that would be fine, but he may never get back. We also thought if he went to Broome Hospital, his needs were so complex, he would be just turned around and brought home. So again, that distress for him to go there and then come back in a short period of time. So these are the kind of decisions that you're making. We really knew that how much he missed Broome, and he hadn't seen his son. I think he saw his son at Christmas. So this is what you're holding at the whole time, knowing his physical issues needing treatment. Okay?
So,
the story continues.
okay, so there was another short discharge. Okay, the decision was to stay in Perth, and then short discharge, another readmission, another assessment, and things were changing daily. Okay, so there were new problems that we were facing and what we were trying to address. I just, at this point, want to just give you a little quick overview of delirium, okay? Because why it was relevant in this case is because this gentleman had hypocalcemia. So the signs and symptoms of hypocalcemia, some of them are confusion, okay? Nausea, drowsiness, constipation, okay? So confusion in the hypocalcemic setting with someone with advanced cancer can present with someone with a delirium. Delirium is undervalued, under-discussed in the hospital settings, and it's something that you will see every day probably in the acute environment. So the majority of patients will recall that their delirium was very, very distressing, okay? And we know this from people that do recover, and they tell us this. The significant thing in the setting for us and for you as healthcare professionals is that if you've got a distressed patient, you've got a distressed relative, yeah? And then when you've got a distressed family, then you've got a distressed nurse, because you're dealing with it. So it just it's like a domino effect. It can all be terrible. Delirium is really common, and it increases mortality significantly in people, okay? People die from delirium. So it's really, really important that it's monitored and picked up. 20 to 30% of hospital patients over the age of 70 will have a delirium, and up to 50% of those with an advanced cancer. And then in the dying stage of an illness, about 90% of patients will have some kind of delirium. In that dying phase, what is it we call it? We call it terminal agitation, okay? Or terminal restlessness, when you see patients that are agitated. And we need to treat it, we need to get on top of it fairly quickly, and we use benzos for that, all right? So it's just, again, I just wanted to throw that in, seeing as though this is an end-of-life workshop. I just thought that was an important point to raise about when you're out there and you see this. So the take-home messages about delirium is really that it is very common and it's underdiagnosed. It's very distressing for everybody. Any reversible causes must be identified and fixed. And trying to use non-pharmacological management, of course, is a part of it. And for nurses, it's really, really important in your practice to try and get a handle on it and recognise it. Again, end-of-life care with Peter, we're just going to talk about, we're not quite sure where things are going with him just yet, but I think we'd all agree, we know that right from the outset, this gentleman, his prognosis is poor, it's bleak, he's going to die from this, it's not going to be cured. And in hospitals now, you're very aware of maybe about accreditation and accreditation processes, you will have heard about them. And as part of Standard 12 now, the care of the dying is actually finally being valued, okay? And it states in there that the care of the dying and deceased consumer, I don't like the word consumer, but that's just hospital, hospital spiel, isn't it? Patients should be managed with dignity and comfort, and family and carers are supported, okay? And in any acute tertiary hospital setting, you're going to be dealing with people that are dying all the time. It is not uncommon. At Charlie's, about 1,000 people per annum die in Sir Charles Gardner Hospital, okay? And the vast majority of those people die in ICU, ED, and general medical wards. not in oncology, actually, or haematology. And that's another story, but that's probably because they've got palliative care involved. And about 300 of those patients per annum are actually referred to our team on average. So we care for about 300 people in the dying phase. So, Peter, he was brought into the emergency department at Charlie's by his family from Crawford Lodge, where he was staying. And interestingly, what had happened is Clara had actually made a phone call to the family just to touch base and see how were they going, how had the weekend gone. They said, oh, look, he's not well, we're bringing him in. So we had the heads up that he was on his way. So Clara and I actually went down to find that he was in the resus bay in the emergency department. So what are we going to do now? We've got a 36-year-old guy. His son isn't with him, his partner isn't with him, his mother wasn't there at that point. He's in the resus bay, and the ED consultant is going, "Hey, what are we doing here? What's the plan?" You know, we're all trying to piece the story together. Luckily for us, we got the heads up, so we went down there immediately. I went into the resus bay. Clara went to attend to the family. So, you know, it's great when we can do this, and when it works well as a team, it really does make a big difference. So we're in there, and you've got three key teams. You've got the ED consultant, who've already called ICU to get an opinion whether we need to intubate and send him to ICU. Okay? And then we'd got us. I took one look at him and said, nah, stop, he's dying. We're not sending him, not going to do anything more. Fortunately for us, the ICU registrar knew the situation as well, and she agreed not to take him to intensive care because that wasn't the appropriate care for him. He was going to die. So what are our goals now? So this is again, you know, we're all getting our heads together, we're rethinking quickly on our feet, we've got to change what we're doing. And our goals are really simple. We just want to provide him with a dignified private death and support his family, who are now grieving. Okay? It's really quite simple from a palliative care perspective. This is what we've got to do. But the problem we're in the resus bay, in trauma bay 1, in the emergency department. And I've got, I don't know, how many, maybe there was 9 relatives at that point, which Clara was attending to. So Clara's got the 9 relatives and I'm with him. And how are we going to achieve this in the resus bay? Because it's a bit of a personal joke, but I do call it the Noah's Ark syndrome. And you get it a lot in the acute care settings, in HDUs, obviously in intensive care and in emergency departments, where they say only 2 relatives can come to the bedside. It's like, you know, ship them in 2 by 2. Yeah? Clearly, if your loved one's dying, is there anyone in this room who wouldn't want their family to be together? You know, how would you feel as a person if you were told, sorry, no, you can't come in, where your 36-year-old brother, son, husband was dying? Do you know what I mean? It's not a good look. So quickly we said, right, we've got to do something. We've got to get him out of here. And so we came up with a plan. There was a lot of phone calls very quickly. Clara's in crisis mode with the family. And we're very fortunate at Charlie's that we do actually have an end-of-life family room up on the oncology ward that we can utilise. So we were able to get together and quickly make up the plan that we were going to transfer him. Now, this may sound really disrespectful, and I don't mean it to sound disrespectful, but from my perspective, I'm looking at a gentleman who was possibly imminently dying. And we needed to move him through the hospital up to the 7th floor to get him into a space where his family could be together with him. At that point, the things that are going through my mind is I don't care whether he's dead or alive, we're getting him into that room, because that's the critical bit. It's not whether he is alive or whether he does pass away at that point. It's whether we get him and his family to be together, okay? So that's the primary goal, and that's the whole focus of what we're doing. So rapid decisions were made. We had a great example that day where the ED consultant, who was actually the head of department, was supportive. At this point, he'd actually got some non-invasive ventilation. We were just trying to keep him alive until we got him up to the room. And what we did was we transferred him. That Clara took all the family up to the room first. We had our other members of our team up there ready and waiting with particular medications and things. And we got him in there safely and soundly, and he was transferred. All happened probably within 30 minutes, actually. It all happened within about 30 minutes, this whole process. And it can work, and it can work really, really well. And I can honestly say I've never felt prouder of being in Charlie's that day, in terms of seeing not just our team, but, you know, all these teams, all on the same page, all looking at the common goal, all respecting that him and his family needed to be together and we didn't need to do anything silly. So we took him up to the Lotus room, and interestingly, we took off the ventilation, we got him the medication, and he didn't die imminently. It was, I think, 3 days later. 3 days later. So for those 3 days, it was beautiful.
Yeah, well, our favourite moment was because in that first day, the family were holding the phone to Peter's ear, and his mum and his sister, who was the next of kin, were screaming down the phone, "You stay alive, we're on our way," and they were screaming. So he probably heard them, and they arrived, and the family came in droves, nieces, nephews. I've never seen so many family coming. And that's when that assessment's still continuing. You're learning all the dynamics between people, the grief issues, what the family have to face in the future, but also thinking about how are we going to get his body back to Broome once he died, so it doesn't just stop with him dying in the hospital, but actually thinking about how he would get back to Broome, his land, his home. Yeah.
So that's it, guys. That is, a quick overview, really, of what a palliative care team does, what we can do, what we can achieve together. And if all I'd like to say to you all is, if nothing else, just be mindful of a couple of those messages about the self-care when you're out there. And just remember, palliative care doesn't mean just the last few days of life. Okay? Thank you.